All right, well, thanks. So I want to talk to you a little bit about myocardial protection. I know the next speaker will be talking about cardioplegia as well, so some of this may be a duplicate. I'm just going to give you sort of my thoughts on myocardial protection and what we've been using in St. Louis at WashU. Not uniformly, but at least that's what I like to use. All right, so cardioplegia, I think, definition. Cardio is heart, plegia is paralysis, so it's obviously the purpose is to provide the heart surgeon with a still flaccid heart. And our goal is obviously to protect the heart during the period of ischemia, so at the end of the operation, we can have a functional heart. Going back to history, back in the 1960s, at the onset of cardiac surgery, normothermic ischemic arrest, or we call fast operators. Fast operation was sort of the way we did surgery. This usually worked, but for some patients, they developed a stone heart, which basically came from depletion of high phosphate molecules in the heart, or specifically ATP. Then came intermittent cross-clamping, cross-clamp for 15 minutes, reperfuse the heart for 5 minutes, and that worked well. Some surgeons still used it, in the 1990s, 2000 to do coronary surgery. It's cumbersome, but it seems to work for patients with short cross-clamp times and good ventricular function. Fibrillatory arrest without cross-clamping was used and again continued to be used into the 2000s at Mass General by one of the surgeons, very good surgeon, very good results for coronary surgery. Coronary perfusion continuously via small cannulas is still used right now by Tyrone David in Toronto with very good results. For aortic surgery or valve replacement, it's by definition almost always intermittent. Sometimes there's spillover, you have to stop it, you have to see, and can cause coronary injuries, and it's also cumbersome. Topical hypothermia with cold jackets and just, cooling the heart with Dr. Shumway at Stanford worked pretty well. Cardioplegia in the 1970s was introduced, and the first solutions were sort of intracellular solutions with procaine and calcium-free solution of Bert Schneider's, or extracellular of Dr. Hurst's St. Thomas solution, which is a high K. Oxygenation was added in the form of mixing blood from the arterial circuit with cardioplegia, and that's sort of the history of cardioplegia in my perspective. Dr. Gay, who is now emeritus professor at WashU, is a wealth of knowledge sort of in the evolution of cardiac surgery. In the 1970s, working at Cornell, showed the efficacy of high potassium cardioplegia. And this is a quote from him when I was talking to him about a month ago before preparing this talk. He said, we were losing patients with severe AS undergoing AVRs, even though they had good EFs, because that's the only patients they operated on back then. They had to have a good ventricle. He said at the time that was considered a very complex operation. He decided to try potassium-induced arrest. Oh, this is my water. While his partner, Dr. Ebert, continued to do the sort of fast surgery thing, and the results were dramatic, and that was the randomization. Things have sort of moved along. So what's complex now, which is sort of the topic of my talk? What are complex surgeries? The way I look at them, those are patients who are with low EFs, patients who are going emergently to the OR from cardiogenic shock from the cath lab, patients who are undergoing complex operations, multiple cardiac defects, long cross-clamp time, and complex operations, I think, can also be minimally invasive operations with limited access, very small incisions, limited vision. We want, minimal cannulations, cannulas in our way, etc. What are the principles of myocardial protection? Again, those are sort of my bias towards what I feel is good myocardial protection. I think first you need to have rapid induction of electrical asystole that limits the loss of ATP, basically, in the myocytes. Hypothermia, I think, is critical. It's the most effective way of reducing metabolic demand of the myocytes and matching as much as possible the limited oxygen availability during cardiac arrest. We want to provide a buffer to protect the heart from acidosis from the anaerobic metabolism that it suffers during lack of oxygen delivery. You want to avoid substrate depletion during ischemia. Again, you want to avoid loss of ATP and ADP and other high phosphate molecules. You want to avoid intracellular edema of the heart and avoid reperfusion injury. In myocardial protection for complex cases, I think has to follow the same thing. You have to adhere to the principles of myocardial protection, like we mentioned. Rapid arrest, hypothermia, avoid acidosis and edema. I think retrograde delivery is very critical in patients with complex diffuse coronary disease. I think then you need to consider adjunctive measures in addition to the broad principles of good myocardial protection. Those adjunctive measures are substrate enhancement with amino acids, perhaps warm induction for ischemic hearts at the time of initiation of the CrossClamp, and reperfusion. So now I'm going to specifically limit the next bit of my talk about three sort of solutions. I think this will be visited a little bit in more detail by the next speaker. But I'm going to talk about the Buckbird solution, Del Nido, and microplegia. So Buckbird in the late 80s, early 90s, through a series of very elegant studies in the lab, demonstrated the benefit of sort of the Buckbird cardioplegia technique. It maintained the 4-to-1 blood to crystalloid mix that had been used in the past, but it was given intermittently every 15 to 20 minutes, both antegrade and retrograde, hypothermia, and the biggest part was the controlled reperfusion at the end of the CrossClamp time prior to releasing the CrossClamp. And the controlled warm reperfusion had several characteristic control of what the myocyte is, essentially the ischemic myocyte is exposed to prior to releasing the clamp. CPD was added to reperfusate to lower the calcium. It was a solution that had low potassium so that the heart can resume electrical activity fairly quickly after release of the CrossClamp or even while getting the warm shot. Reperfusion pressures were kept low to limit the endothelial damage. It was a slightly hyperosmotic solution to decrease edema. Substrate enhancement with glutamate and aspartate, 2 amino acids, were added, and it had to be given for a minimum of 3 and preferably 5 minutes, which seems like an eternity for a cardiac surgeon at the end of a CrossClamp time, but it does seem to help. In terms of the amino acid enhancements, which is a lot of what Buckbird did a lot of studies on, we knew that, and he demonstrated that hearts suffering from antecedent ischemia or failure, so going into the surgery in cardiogenic shock, those hearts suffer inadequate levels of ATP and ADP. They also suffer from limited ability to produce those energy molecules that the heart needs, and they can't produce enough of them because glutamate and aspartate, 2 important Krebs cycle intermediates, are lost during prolonged periods of ischemia. So they enhance their cardioplegia, the warm shot at the end with glutamate and aspartate, and showed that in the lab models, definitely increased post-ischemic contractility. And the greatest gain was achieved if you gave these amino acid enhancements to energy-depleted hearts, so hearts going into the ischemic period already ischemic and in failure. And a greater benefit may have also been achieved if you infuse those hearts with those amino acids as a warm induction prior to cooling the heart and proceeding with the operation. What about the Nido Krejci? So it's developed by Dr. Del Nido in the 1990s at Boston Children's Hospital. And he developed it to specifically address the need of immature and infantile myocytes during pediatric cardiac surgery. It was designed to be given as a single shot antegrade cold cardioplegia that can last up to 180 minutes. It was designed for the neonatal hearts, which have very unique characteristics. So neonatal myocytes have a much better tolerance to ischemia than adult myocytes, but they're also very much more susceptible to calcium influx than the adult myocytes. They have lower levels of sarcoplasmic reticulum calcium ATPase activity, and high intracellular calcium can damage a neonatal myocyte much more so than an adult. These are the components of Del Nido. Probably most of you know about them. Plasmolyte as a carrying solution, mannitol, magnesium, potassium, a little bit of bicarbonate, and lidocaine. And you notice there's no glucose here. It's given as 4-to-1 crystalloid to blood, so it's mainly a crystalloid solution with a small amount of blood. Again, it's given as a single shot antegrade, can last up to 180 minutes, but usually every 90 minutes in pediatric population it's redosed. And one of the advantages of that Del Nido solution is less interruption to administer cardioplegia. So there's, again, no calcium, no glucose. Magnesium is added to diminish calcium influx, and the lidocaine is really used to stabilize the membrane, prolong the period of electrical asystole. Lidocaine also has the advantage of blocking the sodium-calcium channels, and again, reduces the inflow of calcium, which the neonatal myocytes are very susceptible to. Del Nido cardioplegia was developed for infants. Can it be used in adults? Dr. Del Nido always cautions people at meetings and reminds them that it was developed for the neonatal heart, not for adults. But we'll go over some of the studies that we have. Can it be used in adults? There are very few published articles on its use, and certainly no randomized data versus other techniques. Its use in adult cases is really driven by the idea of its simplicity. It's one shot, antegrade, not given multiple times. But again, you have to remember that it was designed for the immature myocytes that are much more resistant to ischemic damage and more susceptible to calcium influx. So there's a few studies. The Cleveland Clinic in 2015 published some data on 85 patients who had AVRs, 110 with MVRs, and they used Del Nido cardioplegia for all of them. They used propensity-matched historical controls. The EFs were all very good at 57% or higher. Most of the patients were in the New York Heart Association functional class 1 or 2. So these are healthy patients with healthy ventricles. And they showed no difference in mortality versus traditional approach, no difference in post-op inotropes or change in EF. The CrossClamp time were a bit shorter, and glucose levels and insulin requirements were less because, again, there's no glucose in the solution. The group from New York, Columbia Presbyterian, published 2 papers on the use of Del Nido in adults. The first one was 88 CABG patients. Again, it was a retrospective study with patients compared to historical controls, propensity matched. The pre-op variables were similar. EF was still fairly good at about 50%. But these were short operations, average of 3 grafts in each group. It was given as single shot Del Nido versus standard multi-dose with retrograde. Again, they showed no difference in mortality or troponin levels post-op EF, but slightly shorter cross-clamp time, about 15 to 20 minutes. The same group also published the results of Del Nido in valve replacement, reduced sternotomy for AVRs. Again, EFs are about 48% on average between the 2 groups. So fairly good ventricles, New York Heart Association functional class of about 2.5, again, healthy patients. And again, they showed no difference in outcomes between the two myocardial protection strategies with the lower cross-clamp time for the Nido. So my perspective on Nido in adult patients is it seems to be feasible to use it in adults, but only in patients who you anticipate a short cross-clamp time for and good LV function. But we have very little data to support that, but it seems to work in a few of the studies that I've showed you. It's probably not a good option if you have a patient with severe CAD, as single-shot antegrade is unlikely to give good distribution myocardial protection. It really needs excellent venous drainage to prevent washout and rewarming, and really must be, its use is basically probably most useful in minimally invasive surgery where you don't want cardioplegic cannulas in your way, where you can just stick a needle in the ascending aorta, give a single shot of antegrade, get that out, suture the hole, don't bother with retrograde or redosing the antegrade. And it's really only demonstrated benefit over normal techniques in adults with good ventricles is slightly shorter cross-clamp time. Whether that has any clinical significance, who knows. Microplegia is the last type of plegia I'm going to talk about, and it's sort of my preferred technique now. It's pure blood delivered with specific drugs added to it. We usually give it multi-dose, both antegrade and retrograde, and its advantages is obviously much less crystalloid administration during cardioplegia, and the use of blood provides the most oxygen delivery. It's a great buffering agent, better than bicarb added to solutions, and it has numerous endogenous scavengers of free oxygen radicals that are produced during ischemia. So microplegia basically has a lot less crystalloid, and this is just an example. If you give 5 liters of plege during a case, 4-to-1 ratio, you end up with about a liter of that being crystalloid administered versus if you use microplegia delivering 5 liters through the case, you end up with 50 cc's of crystalloid administered during the plege to the heart. And there is a difference in myocardial edema, no question about it histologically. And we know that myocardial edema is seen in cardiac surgery and leads to impairment in systolic function, impairment in diastolic function, decreased cardiac output, increased stiffness of the heart, and poor compliance after an ischemic period. And this is some studies about microplegia at the London Health Centre in London, Ontario. They looked at about 1,100 patients undergoing heart surgery in about a year and a half. Patients were divided into either variable dose cardioplegia, meaning the 4-to-1 technique, Buckbird type, antegrade, retrograde versus blood microplegia. The total amount of cardioplegia was delivered was similar in terms of overall volume, but again, crystalloid was much less given. Hemoconcentrator was used in about 44% of the standard cardioplegia versus only 13% of patients having microplegia. And the results were very favorable towards microplegia, with most major post-op complications reduced with a very strong p-value. ICU length of stay, hospital length of stay were also reduced with a very strong p-value favoring microplegia. There's another study from Italy where, again, published about 2012, looking at 80 patients who were randomized to Buckbird versus microplegia, so this is not historical controls, and it showed that in this small study, microplegia strategy reduced troponin post-op, reduced coronary sinus lactate levels, so presumably less ischemia to the heart. There's decreased need for inotropes post-op, decreased duration of inotropes, and decreased transfusion rates because, again, less dilution. This study of about 4,000 patients and from the Annals of Thoracic Surgery, again, compared standard blood cardioplegia this time 8-to-1 instead of the usual 4-to-1, so even sort of getting closer to microplegia during isolated CABG patients, and they showed a lower incidence of post-op low cardiac output syndrome. That was significant, almost cut in half between from 5% to about 2.5%. It decreased post-op cardiac edema and had better recovery ventricular function, reduced ventilator hours, length of stay, and ICU length of stay. And this is the statement from the STS and the Cardiovascular Anesthesia Society that microplegia should be considered to minimize the volume crystalloid in a multimodality blood conservation program, and that was also one of the factors that has led us to use microplegia in St. Louis. So overall, microplegia, in my view, I think offers less myocardial edema compared with traditional strategies of crystalloid or variable mix 4-to-1 or even 8-to-1 cardioplegia mixes. It leads to less post-op diastolic dysfunction and better post-op contractility. We found that we end up using less inotropes. We definitely have less transfusion rates. And we've also noticed that we rarely ever have to cardiovert the heart after we use CrossClamp. They just seem to start working on their own. Or, when you pace them, they start pacing. So to conclude my talk, I think myocardial strategy for complex cases, you have to adhere to the principles of good myocardial protection. You have to have a quick arrest. You have to maintain electrical arrest to decrease energy use of the heart. You maintain good hypothermia, again, to decrease energy demand of the heart when it's ischemic. You have to have good distribution of cardioplegia, which means retrograde in most of our patients. And you have to limit myocardial edema so that the heart can recover better afterwards. I think Buckbird strategies should be used as the foundation of good myocardial protection in complex cases. I think Del Nido solution could be used to facilitate minimally invasive valve cases in adults with good EFs, which I think is, minimally invasive operations are complex operations, and you don't have good access to the heart for, maintaining hypothermia, et cetera. So if you have to do a minimally invasive operation through as small a cut as possible, I think Del Nido solution is reasonable in those patients as long as they have good ventricular function and you anticipate a short CrossClamp time. Probably should not be used, though, in patients with diffuse CAD undergoing CABG, nor should it be used in anyone with low EF. And Dr. Del Nido, again, if you talk to him at conferences and such, will say this was not designed for adult hearts. It was designed for pediatric and really neonatal hearts that are much more tolerant of ischemia, and that's why they can go for 90 minutes or an hour without oxygen delivery. Microplegia, I think, delivered in a multi-dose antegrade and retrograde fashion, combined with hypothermia during the arrest and a warm shot reperfusion at the end, I think provides the best strategy for complex cardiac cases and is worked the best in my hands. I think substrate enhancement with amino acids at the end of an ischemic period is very useful, particularly if you have a really long CrossClamp time or if you're operating on a patient from the cath lab or who's been having a lot of unstable angina and had antecedent ischemia. And in those cases with cardiogenic shock going into the lab, we also like substrate enhancement initially with amino acids, so a warm induction dose. There's very little clinical data to support the use of amino acids, but certainly the experimental data is profound and very, very convincing, and I don't see any reason why it doesn't translate to the clinical arena. But a lot of things affect clinical outcomes of these patients, so it may need a huge a number of patients to demonstrate it clinically, but certainly in the lab models, amino acid enhancement is very useful and very much of benefit. And that's it.